technology itself is advancing. And one of the things that these international guidelines have really took into consideration is the advancement of the MRI machines and how we're able to really acquire sequences that are very important, sequences that are more precise and with thinner slices on MRIs. So they took this into consideration. I think the new guidelines kind of really emphasized into how we acquire our MRIs and also emphasized the standardization of MRI acquisition internationally, which I think is very unique and is very relevant to clinical practice. Yeah, so the panel and the consensus is that 1.5 Tesla is fine to do. 3 Tesla is preferred for the brain, but 1.5 Tesla is also okay. Anything less than 1.5 Tesla, they would not recommend. For spinal cord, though, 1.5 Tesla is fine and 3 Tesla is fine. So they didn't feel that there is an advantage for 3 Tesla for spinal cord over 1.5 Tesla. But for the brain, definitely there is. So one of the things that we really want to focus on is that our patients have access to really quality imaging, and that's part of quality care. So once we have really would say a standardized protocol that follows the MS guidelines, the international guidelines, then our patients are be able to get quality care and quality imaging for their, the money they're paying, their insurer they're paying, and also for us as neurologists, when we review these MRIs, really it gives us the answers that we're looking for. One of the things that was emphasized in today's session is that sometimes patients come in with MRIs that are acquired in a different way that really would require the neurologist to repeat the MRI because of the quality. Going through an MRI is not very easy, right? You're inside the tube, going in there's noise and everything. So we want our patients for this experience to get the best quality and the best care. Sometimes the slices that we look at, the thickness of slice is really very thick compared to what we really want. They do not sometimes obtain 3D or even 2D sequences on several sequences that are very important for multiple sclerosis. There are sometimes, lots of motion artifacts. There are a lot of other things that they don't take into consideration. And sometimes really I find that I get an MRI that has sequences I don't need really for multiple sclerosis, but I'm missing the sequences I need for MS. So one of the things that the international guidelines have emphasized, and I think is very, very important, is that they defined which sequences are important at the initial MRI and which sequences are important also in follow-up. And they said which sequences are optional. Yeah, I think it's very useful because then patients are be very informed into how their MRI need to be acquisition. So if they, let's say they go to a site that they don't know if it follows the international guidelines, then they can say and share with the actual site and say, well, I want my MRI to be done this way because this is what it should be done for multiple sclerosis. And if that place say, no, we can't do this, then maybe they should look elsewhere. So today, actually, several things were discussed, and I think they're very important. One of the things that the speakers touched on was the central vein sign as part of imaging. And this is maybe something that we should probably look deeper into and its applicability into clinical practice, and if we're able to incorporate it in future imaging. The other thing was this paramagnetic REM, where may have some value in progressive multiple sclerosis, where you may see these smoldering lesions where there is some ongoing inflammatory activity within those old lesions that may be present there for a while. But if we see this REM on specific susceptibility imaging, that may help us, kind of guide our clinical decision. The other thing that was, maybe touched on a little bit, but maybe it's something more for the future, is brain atrophy measures and the quantitative MRI. And this is something that still needs some work. This is something that still need more research, as we say, but it may have some potential into being able to follow the volumetrics of the brain as we go reliably in clinical practice.
COVID affected how I logistically managed my patients with MS. So I was not a clinician who was taking people off certain therapies during COVID. I still really feel like MS is the most important thing to worry about during the COVID pandemic, as long as we can advise patients to take appropriate precautions. My biggest problem was getting patients to still get to the lab, still get to an appointment. There are certain things that we can't do virtually, right? So it was really in just convincing people that we were doing things as safely as possible and that we needed them to continue to manage their MS so that it didn't run rampant during our pandemic. Very fortunately, early on, we started talking to people about whether or not they needed to stay on therapies, whether or not we needed to do extended dosing intervals of certain therapies. And I think the consensus came back to, we need to manage your MS, because as more people got COVID and we developed more data, we realized that having MS in and of itself wasn't a risk factor for more severe disease or for contracting the disease. So we wanted people to stay as healthy as possible, which means managing their MS appropriately, staying on their therapy. One of the best things that happened because of COVID, I think, was that a quick adaptation of telemedicine and the ability for us to hopefully continue to use it in a way that's effective for everyone. And an example I would give would be a person who drives to an MS center 2 to 3 hours for an appointment and is very fatigued by the time they get there. It messes with the day, so to speak. Another example would be a person who's having an acute relapse and there's no appointment available for them in the office, but maybe they could do a telemedicine visit. So for these reasons, I think we should eagerly adapt that into our practices, because it makes life easier for people living with MS and it enhances our treatment of them. Contracting COVID would be a particular risk for people living with MS who have the other comorbidities that are a problem with the COVID pandemic, like diabetes, hypertension, obesity, certain cancers, heart disease. Additionally, people living with MS who are older, who have more progressive disease, who have higher levels of disability, and who are on certain disease modifying therapies, we think, like B-cell depleting therapies. So yes, there are certain groups of people that we need to worry about, but in general, we have really wonderful folks contributing to the CoV-MS registry. They continue to reassure us that people living with MS can live healthfully through this pandemic, continue to manage their disease, and stay free from the virus. I started seeing the mental and emotional effects of the pandemic at the beginning of March, before we knew what was happening. And I think by and large, what I've seen in my integrative practice and in my conventional practice is there's just a really heightened problem with anxiety and managing that. From an integrative standpoint, the great things that I see are that people are more willing to adapt self-care practices like mindfulness, meditation, yoga, regular exercise. They're more interested in becoming empowered in learning about the things that they can do in their homes to help them live more healthy lives. Yeah, so very fortunately, these things that we do for self-care, they help us to feel better. They very likely help decrease feelings of fatigue. They increase feelings of well-being. They can help manage pain, sleep, and anxiety. And so I think as people adapt these practices, they just naturally become things that they want to continue.